with the exception of yourself, Dr. Tselios, and during the presentation.
Okay.
So I would like to welcome everyone to our monthly webinar. It is great to see so many of you there, so many of you here actually. My name is Sandra Williams-Reed, and I'm the Support and Education Committee Chairperson with Lupus Ontario. I joined the board about a year ago, and we've been, of course, because of COVID, we've moved all our events online. So we have all our support groups, which are currently online, as well as our monthly webinars, which are held, which are online. So just before we begin, I just would like you to know that you are being, this video webinar is being recorded. Just for your own privacy purposes, just so you know, it is being recorded. It is a great pleasure to have with us Dr. Konstantinos Tselios. Started working in the field of systemic autoimmune diseases during his specialty training. He found his calling in medicine when he engaged in clinical research in systemic lupus for his PhD thesis. After completing that, he was awarded the Geoff Carr Research Fellowship from Lupus Ontario in 2014 and the opportunity to come to Canada. He was further trained in the Toronto Lupus Clinic under Doctors Urowitz and Gladman for several years. In January, he started a new chapter in his life by becoming an assistant professor with the Division of Rheumatology at McMaster University. In the near future, Dr. Tselios hopes to establish a lupus clinic and biobank for research purposes in Hamilton, with the generous support of Lupus Ontario. Thank you, Dr. Tselios, and welcome. You may begin.
Sandra, thank you so much. The pleasure is all mine, actually. I don't know if most of you know my relationship, are aware of my relationship with Lupus Ontario. Lupus Ontario was the opportunity for me to come to Canada. Right back in 2014, there would be no other way. If I wasn't awarded the Geoff Carr Fellowship, that story and that relationship wouldn't have happened that simple. So I'm grateful for this and for the support Lupus Ontario has given me, to my family, and now to the McMaster Lupus Clinic. We are trying to do something up here in McMaster, and I hope that I'll make it. For the moment, and this goes to the board of directors as a heads up, I'm preparing the paperwork actually required to get approval for research from the McMaster Research Ethics Board. So this is where we stand. And without this approval, we cannot move forward and we cannot start doing this. I hope and I trust that the administrative authorities here at McMaster will grant me the approval in May. So most likely we'll start in May. I'll let you know. So without further ado, a few things about the pandemic and how this affected the lives of patients with lupus. I hope you can see my screen. All of you, okay? Okay, great.
Yes, we can.
Right. I thought about this and I thought that I should present some things chronologically. I'm following the pandemic since the very beginning, both in Canada and in Greece. They had a very similar course, actually, Ontario and Greece. They didn't do their best, in my opinion, but in any case, they did relatively okay. So I will present this in a chronological order with emphasis on what happened to the lupus community and what happened to the lupus patients. We'll discuss a few things about how the virus is really affecting lupus patients. We'll see what are these variants? What is this new thing? Like every week, every month, we hear about a new variant, and we are full of concerns of what will happen in the future. And if we ever get over this, right? And then a few words about the vaccines and what we should do with the vaccines. What are the concerns with specific vaccines or not so with others? Right, probably you've seen this picture in the upper right corner. This is the famous, now infamous coronavirus. Coronavirus, these red things are the spikes, the spike proteins, and this looks like a crown to somebody's imagination. Corona is the Greek word for crown. So that's why they called it coronavirus. We knew that from 1950s, 1960s, we had a few coronaviruses out there. They were causing what we call common cold, right? Some nasal congestion, some sore throat, and that's about it. In 2003, we had the SARS-1. It hit Canada like really, really badly. We had no idea in Europe of what's happening in Canada at that time. There was not a single case in Europe, so we didn't have any experience with this. And now the second version, the updated version, the advanced version of the SARS-1, the SARS-2, affecting more than I think it's 140 million people affected worldwide, with more than 3 million deaths as we speak. Anyway, this little virus causes these red proteins to get attached to some molecules on the surface of the cells of the respiratory system in the lungs. Then it gets into the cells and it destroys them. Right, this is a picture of a heavily infected cell in the lungs, like multiple small viruses, the yellow or light green parts, and the blue big one is the cell. So the virus will attack the cell, will get into through these back doors. We all have these back doors. It's normal. It's not that the virus makes it. No, we already have this. And the virus finds this back door and gets into the cell. And when it gets into the cell, it will start reproducing and reproducing until the cell is killed. And then it will jump off to the next cell, and then to the next cell, and then to the next cell. This will happen most commonly in the lungs, right? And this is why people have trouble from the lungs. And we call it COVID pneumonia or COVID-19 pneumonia. COVID stands for coronavirus. This is 2019, and we say COVID-19 for short. In the left panel, you can see a normal chest X-ray. I don't want you to understand much about this, but wherever you see black, there is air. Wherever you see white, it's not air, it's the lung tissue. We need it to be like this. The lungs are full of air. In case of COVID, you see more and more white here. These are serial X-rays from a patient showing more white stuff in the beginning, and then more and more and more. So less black, so less air in the lungs. So the patient goes into what we call respiratory failure. And the patient needs to be supported with the ventilator, with a tube, in order to push the oxygen into the blood. A similar story with the CT. Right, now try to imagine that the patient is lying supine on the bed, and the bed goes back and forth, and we see slices actually of the lungs on the screen. On the left, you can see a normal respiratory system, normal lung, full of air, black. This white stuff are the interstitial tissue, but it's so thin that the oxygen can go through this into the blood and supply the brain and every organ in the body. In the case of COVID pneumonia, this is happening. Everything is solid. There is not much air in the lungs. This is why the people are intubated, getting into a ventilator, and if they don't respond to a ventilator, people will essentially eventually die. That was until yesterday. We had more than 1 million cases in Canada, more than 23,000 deaths. The third wave, we didn't do so well. Actually, we had the same cases per million with the United States of America. You all know what happened south of the border. Now they're doing better and we are doing worse. So we need to get up to speed again somehow. What's happening in Ontario? We had a lower mortality ratio. We did better. Why? Because we had the ICUs, we had the ventilators, we had the infrastructure to support these patients. If it wasn't for the first wave of the pandemic, that we have to admit that we were caught off guard, particularly when it comes to the long-term care facilities. I think we would have done better. So from these almost 8,000 deaths, you know probably that less than 1,000 are in patients less than 60 years old, less than 300 are in patients less than 50 years old, right? And for these patients, most of them had significant comorbidities, autoimmune diseases being one of them. Now, as we speak, we have 555 patients in the ICU, 516 in the ventilator, the tube that pushes oxygen into the patient's system in order for him or her to survive. Now, anyway, after this general issues, what happened in the lupus community and what affected us as a community? I mean, I speak both for patients, mainly for patients and doctors and caregivers from the very beginning. You probably remember that in March, we were fighting over Plaquenil. We didn't have Plaquenil. Plaquenil was gone. There was nothing in the pharmacies. And that was significantly increasing the stress of our patients, the uncertainty of our patients. We were fighting to find the last reserves of Plaquenil and chloroquine. Chloroquine was wasn't existing. Why this happened? Because this guy, his friends, he's one of the best infectious disease specialists in the world, admittedly, published a paper showing that Plaquenil is working against the virus. Right, the first publication was, if I'm not mistaken, 20 patients, then the second was 60 patients. And they were measuring the viral load every day in patients who had been infected. So they were testing them every day under Plaquenil treatment, and they were seeing that whoever was taking Plaquenil was doing much, much better compared to patients who did not take anything. Right, now, if you Google him, as we speak, he has this IHU Mediterranean Center in Marseille, France. He says that he has treated about 5,500 patients with Plaquenil plus Z-Pack azithromycin. Z-Pack, Z-Max, azithromycin is the active substance anyway. And the role of it is to clean up the respiratory system to prevent any microbial infection that may come over after the viral infection. And up to now, he says that 15 of his patients died for a mortality rate of 0.3%. Anyway, in the beginning, when we knew nothing, we only had these small trials with 60 patients, with 20 patients. We didn't know what to do with the virus. And we decided as a global community to go to the pharmacies, buy the stuff, give it to patients, give it to friends, give it to family, stock it, hoard it. In Europe, for example, you can walk in the pharmacy and buy it. Actually, you don't need a prescription or anything. You can buy as many as you like if you have the money to pay for it. And trust me, in Greece that I know well, like the monthly cost of Plaquenil is 2.5 euros. That goes to 4 Canadian dollars. Not a big deal. Anyway, this was a significant stress for our patients. And we asked a few rheumatologists, 134 rheumatologists across the country, if they were contacted by the patients for this shortage of Plaquenil and what happened. And 60% said yes, there is trouble. Most of them in Quebec. I'm not aware of what happened exactly in Quebec, if there was any other, something else happened, if other people were able to find, to buy Plaquenil. But anyway, 50 patients per physician were affected by this shortage in Quebec. And then, to make things worse, we had to report an opinion paper, not paper with data on actual patients and things like this, that was published. In that Annals of the Rheumatic Disease, we see, you see this on the left panel. Why I put it there? Because the Annals of the Rheumatic Disease is the holy book of rheumatology. Whatever gets out there is automatically respected from the entire scientific community, right? It's like the gospel for Christians, the Quran for Muslims, it's the holy book. Okay, whoever is publishing out there is like semi-god or something. We do this, I do this, like I have some papers in the annals and I'm proud of these papers. But anyway, these guys got out there and say, no lupus patients with COVID-19 worldwide. Why? Because lupus patients are taking Plaquenil. Could this be possible? No, that was like the most stupid opinion I ever heard, I read in the last 12 months. Why? Because you don't expect, even if Plaquenil was working, it would be impossible to prevent the virus from coming into your system. In order for Plaquenil to work, you need the virus to come into your system, get into the cells, start replicating, cause all this damage, and then the Plaquenil may get you better by a difference of 5 or 6% compared to patients who will not take Plaquenil. It did not show any significant benefit in what we call randomized controlled trials, the most reliable studies in medicine. So we abandoned it. Anyway, we started seeing the first cases in lupus patients. The first one was in China, very mild symptoms, recovered. The second one was in Turkey, in a patient with a kidney transplant. She did well, no significant issues. And then we saw a global effort started from doctors in Australia. It's called the COVID-19 Global Rheumatology Alliance, and you can go as a doctor and as a patient and register your data online in the repository, safe repository, from all over the world. And these people collect data from all over the world, patients with rheumatic conditions, not only lupus, right, to see what are the outcomes of COVID-19 in patients with lupus and other rheumatic diseases. So even in May, they already had 110 patients, 19 with lupus, had been reported from different rheumatologists around the world. Then a few weeks after that, in June, they had 80 lupus patients. 64% were taking hydroxychloroquine, the Plaquenil, and they found that there was no effect of the Plaquenil on the risk of hospitalization, admission to the hospital, or ICU. Anyway, what we learned from this is that lupus patients are not immune. Or, to put it better, Plaquenil users are not immune to this COVID-19. In June, we had the first case series from France. 17 patients got lupus. All of them were long-term Plaquenil users, age 53, the mean age, right? They had comorbidities, other comorbidities apart from lupus, that have been shown to affect the course of COVID-19, like obesity. It's not good. Why it's not good? Because people with some extra weight or with more extra weight are vulnerable to all infections. And if these people need to get intubated, it's really, really hard. I'm saying this because I do have some experience in ICU. I had my training for 6 months in ICU. These people are hard to ventilate. This tube I was telling you that pushes oxygen into your system is not working as effectively in big people. Okay. People with coronary artery disease, all of them were taking the Plaquenil anyway. Most of them were hospitalized. Why? Because in the very early phase of the pandemic, we thought that any lupus patient should be admitted in the hospital with the COVID, because we thought that most of them will not do well. In any case, 2 out of the 17 people died at the time of publication. And we'll see why this is happening. Now, I have it in forms of questions. Okay, if I was a lupus patient, and I think that I have a, not a great grasp, but say some grasp of your reality, of your concerns, of what you're thinking. I would ask okay, I have lupus. Am I at increased risk of contracting the virus? Like, what's happening with the person next to me who does not have lupus? Multiple studies, conflicted results, until we did the meta-analysis. Meta-analysis means that we took 62 studies from all over the world, enrolling more than 300,000 patients with autoimmune diseases in general, not only lupus. And they came with the conclusion that it's twice as likely, if you have an autoimmune rheumatic condition like lupus, to contract the virus. Right? This is not absolute. Contracting the virus depends on all these factors that you see here on the right panel. Sorry, I'm trying to, okay.
Yeah.
Like the regional population density, income level, age, right? You understand that it's different for a person who lives in a dense area in an apartment building, and different in a patient who lives out in the country in his or her cottage and gets out only for groceries. Their exposure is different. Number of workplace social interactions, smoking, diabetes, asthma, all these things are significant factors. So this double the risk is not absolute, but anyway, we believe that patients with lupus do have an increased risk to contract the virus. Okay, so I got the virus, right? What's happening after that? Do I have an increased risk of how this will end? Well, I'll end up in the hospital and ICU. What's happening? We had 600 patients from the Alliance, 85 with lupus, and almost half of them were hospitalized. What they found, however, was that prednisone above 10 milligrams per day doubled the risk of getting into the hospital. Right, for lupus patients, prednisone above 10, for most of them, means that they have an active or not absolutely controlled disease. So they have some disease activity still, and their risk is double to get into the hospitals. Other immunosuppressives, they said no, significant risk. Anti-TNFs are some medicines that have been used in rheumatoid arthritis, other arthritis, and there was no additional risk, but on the contrary, there was some benefit. The other factors were age above 65, hypertension or cardiovascular disease, lung disease, pre-existing lung disease, and diabetes. And then we had this report from Spain, similar results about the risk of hospitalization, and another meta-analysis of 65 studies, almost 2,800 patients with autoimmune conditions, 1/3 of them were hospitalized. Why? Because of these factors. Now, you probably see this one here. Whatever comes right to one and the line does not touch this one is a significant factor that affects your risk of hospitalization. So all these factors, above 65 years, hypertension or cardiovascular disease, lung disease, diabetes, and this stands for renal disease, chronic renal insufficiency, or end-stage renal disease, dialysis. All of these factors affect the risk. The others, no. And then prednisone above 10 milligrams per day, as we said, almost doubles the risk. Okay, so we got into the hospital, right? We were admitted. What will happen there? How likely is that the lupus patient will end up in the ICU? It's 3 times more likely, right? Other risk factors, they say like obesity, non-white race, blacks, unfortunately, and Hispanics were most, like the hardest hit ethnicities in the US. History of lupus nephritis, we talked about that chronic renal disease. And cardiovascular disease, a previous heart attack, even hypertension was a significant factor to affect the risk for ICU admission. Okay, we got into the ICU. What's happening after that? From the same meta-analysis, we found a mortality of 6.6%. This is about 4 or 5 times the mortality of the non-lupus patients with the same comorbidities. So it is a risk factor. Okay, most of the lupus patients will do well, yes. And this is encouraging, and this is great. But the relative risk of lupus patients to end up in an ICU and eventually pass away is higher than non-lupus patients. And on the right side, this is irrelevant to the lupus community, but I just put this here in order to make you realize that it's not, the full picture has not been analyzed yet. We don't know a lot of things, why they happened. We have missed probably thousands of deaths that were not counted as the toll of the pandemic. This light blue line is what was expected from previous years. So from previous years, we can make a projection and we'll say that, look, this number of deaths is expected in April 2020 and in May and in June, right? With the red, with the blue, dark blue is what happened, what actually happened. And this bump is here for April and May. With the red is like expected, plus COVID-19 deaths is exactly almost that, right? So many deaths of COVID-19 were not as thoroughly documented, and we'll get to know about this more in maybe years to come. This is another study from France. They showed more or less the same thing. They had this, I put this here because this is from a national registry. So they checked the entire country of how many patients were hospitalized with or without COVID infection between March and October. So for 7 months, they had data of all the patients with lupus who ended up in a hospital in France, in the entire country. So if you do the math, actually the mortality outcome, the poor outcome, the authors say here, is almost 3%, 2.8, right? And when you see a p-value here of less than 0.05, this means that these guys here had significantly more chronic kidney disease, diabetes, high blood pressure, cardiovascular event history, lupus nephritis history, whatever we said for the other studies, the friends confirmed it. Now, okay, we got the COVID. Most lupus patients, thankfully, survived. Some of them at home, some of them in the hospital, some of them made it through the ICU. But is this the end of the story? No, unfortunately, no. We now know that the virus, that SARS coronavirus 2, triggers flares in lupus. The first case was published in September 2020, and now we have several cases of flares in our patients. Why this is happening? Because this virus causes severe inflammation, and this inflammation will trigger the immune system. And the immune system, a triggered immune system, you know better than me, that will not only clear the virus, but it will attack your own body. After the clearance of the virus, you may experience like joint pain, rashes, even full-blown flares with kidney involvement and stuff like this. This patient here, unfortunately, died not because of the virus, but because of this Evans syndrome. This is a not so rare complication of lupus. The platelets that are responsible to clot the blood if you're injured, so you won't die, you will not bleed out, right, are so low that they cannot do the job. The patient died from bleeding, from hemorrhage, right, because of a lupus flare. Is it possible that the virus can cause new cases of lupus? New patients will be diagnosed because of the virus? Most likely. This is what I'm trying to study now. And we submitted a grant here with other researchers from the McMaster University. There are 6 patients worldwide, from the US to Morocco, Italy, Iran, Mexico. And I have the impression that we'll see more and more patients coming out of this COVID-19 with not only lupus, but autoimmune disease in general. Now that I studied everything related, and I'm preparing to publish a paper, we are talking about 255 cases with autoimmune conditions after they cleared the virus. So they did well from the COVID-19, but now they have a systemic autoimmune disease, these patients. So I'll may be able to tell you more about this in the near future, but we know for sure that this will happen. Now, apart from this, if we go back in March 2020, and I'll tell you what I learned from my interaction with lupus patients all these years and the interaction with the community. The lupus patient develops a special relationship with the doctors. I don't know if other patients are doing this, but I think that we have a relationship that is not typical, right? So what happened to the patients in China, for example? 60% missed their appointments because they went to a lockdown. Only 13% had a call from a doctor or a nurse or someone from the team. 25% discontinued their medicines, half because of limited access to healthcare. The Chinese closed even the pharmacies in the very beginning. And 5% developed a flare. something similar happened in Italy. That we can say that this was only observed in an eastern country with distinct characteristics or anything. In Italy, in the European Union, 11% of the patients discontinued the therapy because they didn't have enough communication, adequate communication with the doctors, and 8% of them fled. So we didn't only have the virus as an issue, we have lupus as an issue as well, right? And even worse, we didn't do well when it came to mental health. Mental health is, like, you know better than me, that is very significant. In your case, this is a study from Italy again. They checked 134 lupus patients, 589 non-lupus patients, and they found that the anxiety was 4 times worse in lupus patients, depression more than 4 times worse, and insomnia was 7 times worse. So I know from personal experience, all these years working with lupus patients, that you're not sleeping well, and I can't even imagine what this would look like. Not be able to sleep as this guy over here, but getting more and more anxiety. This was a study that they did in UK. What they found was, when they checked all these variables in a group of lupus patients during the lockdown in the UK, something similar to us, and they compared the results to the second group, a historical group, patients who were administered the same tests and the same questionnaires 1 year before the lockdown. So they didn't have any lockdown at the time, right? So you will see that everything is worse except for hostility. I don't know why this happened, and patients with lupus were like more friendly during the lockdown, but everything else was so severely affected. And that GSI, the Global Severity Index, this is an index that combines all these variables, was almost 3 times up in patients with lupus during the lockdown. And these are a few quotes from people from the UK, lupus patients from the UK. I understood fear, panic. The first patient says, I felt afraid and quite panicked, which led to a massive flare, which lasted 6 weeks. I don't know if I will ever feel safe again. That insecurity from the first days of the pandemic. Then another patient, flaring badly, unable to get hold of my rheumatology team to help me, much more depressed than I was before the coronavirus outbreak, partly due to isolation, and I felt very vulnerable due to my inability to get the medical support I needed. But I also saw resilience, the resilience of the lupus community, the resilience of the lupus patients. We're a group of people who know how to deal with this. We have been through worse, and we survived, and we won't give up now. We're all fighters who know our bodies better than anyone. Anyway, this is what happened with the lupus community, right? The data are few. You understand this? We're talking about little numbers here, but anyway, I think that we'll have more in the near future. Now, a few things about the variants and how and why this could be of concern. In Canada, we say VOC, variants of concern. The most significant for the moment are this from the United Kingdom, the British variant, the South African variant, and the Brazilian variant. In Ontario, 90% of the cases you hear daily are the British variant. This from the United Kingdom. How important is this? It is important because it's more efficient when it comes to transmission. It can jump from person to person more efficiently. So in the beginning of the pandemic, we were saying that one person may infect 2 or 3 or 4 people. Now this will be 3 or 4 or 5, or 4 or 5 or 6. Okay? Some studies report that some vaccines have reduced efficacy, they're less effective against specific variants. Why? We'll see about this. What is a variant? It's a mutated virus. So the initial virus is like this, with these green spikes here, and then for some reason, it gets red spikes, and then dark red spikes, and this is supposed to be more dangerous from the initial one. When a virus gets into a cell, it starts replicating itself again and again and again, right? And he will make clones. He will make, say, hundreds, thousands of siblings. These siblings, almost all of them look alike. One sibling may not look alike. Something may go wrong. When you do this thing again and again and again, in one occasion, something may go wrong. Most of these cases that go wrong do not survive. They are weaker than the initial virus, so they will die first. 99.9% of the mutations are that way. 0.1% of the mutations, or maybe less than 0.1% of the mutations, will go the other way. They will be stronger. The siblings will be taller, maybe more handsome, maybe they have nice hair, maybe, I don't know. They will prevail. And if they prevail, the others will go away because this stronger sibling will start replicating again. Now most of you are cooking, I guess. So imagine that you're doing something, you're preparing a meal for your family, and you're doing this 100 times, right? Most of the times will be the same, or more or less the same. Say sometime you went to the grocery store and you forgot something. So the final product will be less tasty, less delicious, right? So probably the next time you forget about this and you will go to the old recipe and you'll remember, oh, I forgot this, so better take it this time to make my family happy. This will happen again and again and again. Most of the times you will have forgotten something in the grocery store. You were distracted by something else and you didn't add some spice or whatever, right? But sometime you may have an inspiration and do something that is better than the previous time. Then, if they like it, if the family likes it and you like it, you will continue doing it this way, right? So this is a mutated virus. The virus, as long as it's replicating, as long as it's affecting people, it will continue to mutate and give new variants. And you will hear about the Californian variants, the Australian variants, the Chinese variants, the Greece or the North Pole variants or whatever. Why you will hear about this? Because these people are checking it and they're testing it, and they have the means to find it. The UK, for example, follows these mutations systematically since day one. So they were the first to find it. In South Africa, British scientists found this as well, right? And now they are following these variants and other variants all over Europe for sure, in Canada for sure, in the United States for sure. So most likely we'll hear for something else, a new variant here and there. We'll see how it goes. When it comes to Canada, this is the picture at the moment with bright red. We're talking about the UK, the British variant, that B117. And then we have some from South Africa and some less from Brazil. I heard that the Brazilian variant is more in British Columbia. I hope that it will not spread. Okay, a few words about the vaccines. These are the vaccines on the left panel that are available worldwide. We have the Pfizer the Moderna, the Russian vaccine, the Novavax from the US. This is from AstraZeneca. It has the Sweden flag here. That's nice. The company is British, but anyway. Then the Johnson & Johnson and the Chinese CoronaVac. And this is the effectiveness. How they calculate the effectiveness. They give it to all these people. Half of them will receive the vaccine. Half of them will receive something called placebo, like a fake drug, a fake shot. And then they will follow these people until they get the virus. Right? When enough numbers of the participants get the virus, say 30, this is pre-specified, say 30, say 50, say 100, then they get this 100 and they say, how many of you had received the vaccine? 5. How many of you had not received the vaccine? 95. So the effectiveness of the Pfizer vaccine is 95%. Right, and so on for the Moderna vaccine, the Sputnik, the Russian vaccine, and all those things. And this is the cost. Okay, we don't care for the moment about this, but anyway, just so you know, the Pfizer vaccine that you have in Canada is about $20 US per dose. The Moderna goes almost double, and the Astra is $4 per dose. What's happening with the variants? And this is the great question, like why, and we're still, the vaccines we have now are still effective against the variants? Yes, yes, and yes again. For the British variant, the prevailing variant in Ontario and in Canada in general, the same efficacy, absolutely the same efficacy. There's no difference. There is the same efficacy. We have data for the Pfizer vaccine, for the Brazilian variant, and for the South African variant, we know that all of them had reduced antibody levels. And for the AstraZeneca vaccine, the efficacy is 10 to 20%. So this might be trouble. That's why we have to contain it soon and effectively. What's happening with the vaccinations in Canada? Okay, not great, not bad. I'll show you why. We have now, this is up to 10th of April. For the moment, we have close to 23, 24% of the population in Canada have received at least one dose of any of the vaccines. Most of these vaccines are from Pfizer, more than 5 million doses. Another 1 million doses from the Moderna vaccine, and close to 700,000 from the AstraZeneca vaccine. Right, most of the elderly have received at least one dose, close to 85%. Most of the people in long-term care settings have received at least one dose, and then most 90% of the healthcare workers, and I hope that will reach 100% soon. Are they safe? They are safe, and we'll talk about this later. We have administered 7.5 million doses in Canada, and we had 3,444 total adverse events for 0.05%. That means that you have, it's 1 in 2,000 people will have an adverse event. What is this adverse event? I'll show you, but most of them were not serious adverse events. When we say serious adverse events here, we mean an adverse event that may result in death, hospitalization, prolong the duration of hospitalization, or be life or organ threatening. Like a severe anaphylactic allergic reaction is a serious adverse event, right? This is happening in more than 16,000 doses. And I added this. I understand your concerns. We had 2 cases at least until yesterday. I don't know if anything else came up in the news or something. We had 2 cases with this strange clotting disorder that was observed after vaccination with the AstraZeneca vaccine. They had multiple cases in the European Union with a rate of 1 to 500,000 or 1 to 1 million doses. So a rare event, but anyway, in any case, it is proven now that this is related to the vaccine. The vaccine is causing this. Only the AstraZeneca vaccine, not the others. In Canada, we had 500,000 doses to see the first such side effect, adverse event in Quebec. That happened, if I'm not mistaken, 5 or 6 days ago. A woman, we don't know the age, but she's doing well. Okay, already recovering at home. And then a man, I think on Saturday in Alberta, is the second case. He's doing well as well. Now, these are the rates of the reports of adverse events per 100,000 doses from the Pfizer. This is the non-serious, some pain in the site of injection, some warmth in the site of injection, things like this. For Moderna, close to 100, and the Covishield and AstraZeneca are the same. Covishield is produced in India for the AstraZeneca company. These are all the adverse events. We're talking about vaccination site pain, erythema is redness in the area, some swelling, some itching, some headache. It happens. We had anaphylactic reactions from all vaccines, if I'm not mistaken, 63 or 64, after 7.5 million doses. So I wouldn't worry. All of these patients were treated on site. I have personal experience because I'm vaccinating people in Hamilton, and we have all whatever we need to cope with an anaphylactic reaction. Anyway, we didn't have any up to now, but in any case, we are prepared. Now, this is the last slide, then we'll go to discussion and questions and answers. This paper came out about 2 weeks ago. What does it say? They took 123 patients with rheumatic conditions, right? 24 of them had lupus. The others had inflammatory arthritis, stands for rheumatoid arthritis, Sjogren's syndrome, blah, blah, blah. But anyway, 24 were lupus. And they gave them a vaccine, Moderna or Pfizer, the mRNA vaccines. You see it here. And then they checked the blood for antibodies from day 18 to day 22 after the vaccination. So by that day, you should have mounted a response. We should be able to measure some antibodies in the blood. What happened in reality? 32, like 1/4 of the patients, 25% of the patients with rheumatic conditions did not have any antibodies detected at that time. So this means that these patients were not protected against the virus. In lupus, you will see that 16 had antibodies from the 24, 8 did not have antibodies, so if it's even worse. It's not 1 out of 4, it's 1 out of 3. Why this is happening? The numbers are small to draw a definite conclusion, but we believe that mycophenolate, this is the CellCept or Myfortec, is related to this. People who take Myfortec or CellCept most likely will not develop a robust immune response. And this rituximab here, the rituximab is another medication. I don't know, it's Rituxan is the name in Canada. I don't know how many of you are using this, but it's quite rare in lupus. We use this in very, very specific conditions for the patients. And of course, we know that patients with rituximab will not have any good antibody responses because the rituximab is killing exactly the cells that produce the antibodies. So you cannot, even if I give you 10 vaccines, you will not have any antibodies because you cannot produce these antibodies. So what are my thoughts about this? My thoughts are that lupus patients, unfortunately, were not included in the phase 1 or risk 1 or whatever the government is characterizing this. I know that patients with transplants were allowed to have both doses the way we did that in the trials, like in 4 weeks' time or 3 weeks' time. And I think that not only this, our patients with lupus, particularly those who are taking immunosuppressants, should do this the same. And I think that our patients, particularly with these drugs, should have this tested for free a couple of weeks after the vaccination to ensure that they have an adequate immune response. We cannot afford to have our patients out there, like 1/3 of them will not have any antibodies after the first dose, and we'll have them out there for 4 months until the second dose, right? Not knowing how they're doing. Anyway, we'll discuss about this. I'm sure that we'll have you will have your questions. Thank you very much for. I'm really honored. I have no words. I have no words to thank you all. Thank you to the board of directors for this. It's really, it means a lot to me, and not only to me. I want you to believe me. Thank you, and it's open for questions.
Okay. Okay, so Sarah and I will be monitoring the chat. We do have a few questions. So Sarah, you can start with the first question, and then I will continue. I did type in the chat just for everyone information. The presentation is going to be available online. So if you do need some more information to follow up on what Dr. Tselios has discussed tonight, we will have the recording and the information posted online as well. Okay, so we will start with our question. I know Dr. Tselios has about maybe 20 minutes so hopefully we'll get to most of these questions. We'll get through them as soon as we can. Yeah. Okay, Sarah, please go ahead.
Okay, thank you. Our first question is from Sue. What are your current thoughts on which vaccine mechanisms pose the greatest risk of potential flare?
Sarah, thank you so much. If you could repeat the question, I was actually trying to maximize the screen so I can see you all.
Okay.
Okay, if you could stop sharing if you like, Dr. Tselios. And
I'm not sharing. I am. No.
Okay. Yes. All right. Thank you.
I'm sharing my screen still.
Yes. Yes, you are.
Okay, stop share. Okay.
Okay, perfect.
Is it better?
Yes, we can see your face fully now.
Okay, great, fantastic.
Okay, so I'll repeat that question. Can you hear me okay?
Yes, absolutely.
Yes, okay. The question is from Sue. What are your current thoughts on which vaccine mechanisms pose the greatest risk of potential flare?
You mean vaccines and flares? Right, so the vaccine causing the flare of lupus.
Yes,
correct?
that's right.
If I'm not mistaken. If I'm not mistaken, if this is the question, we haven't witnessed any flare coming from the vaccine.
Okay. All right.
Advice in general to to all of you is this: one, if your disease is stable, that means that if you're taking a stable doses of prednisone and low doses, stable dose of immunosuppressives and stable dose of the plaquenil and everything, go have your vaccine. Okay, go have your vaccine. If your disease is unstable, for example, you're taking large doses of prednisone, you're taking 20, 30, 40 for a reason. You were just introduced other immunosuppressants like Cellcept, like azathioprine, the Imuran, like methotrexate. Something is not going well, your rheumatologist most likely believes that your disease is not stable, it's active. In case of active disease, a vaccination is not a good idea. Why? Because your immune system is already active, is already attacking your body, is already awake and alert, and it marches against your body, right? If you trigger it with the vaccination, you will make things worse. This will not be a flare of the disease. This will be the continuous of the activity of the disease. Flare is like the disease was quiescent, no symptoms, no nothing, and I was taking stable dose of medications, and then something happened and everything went south. Right? We have not witnessed a flare from the vaccine, from any vaccine yet.
Okay, thank you. Next question. Is the risk for getting infected with COVID higher for patients with SLE or APS?
For SLE, for lupus, patients with APS, the APS stands for something called antiphospholipid syndrome. It's a thrombotic complication. Patients with antiphospholipid syndrome without lupus or scleroderma or whatever, like what we say primary antiphospholipid syndrome, are not treated with immunosuppressives. So their immune system is not weakened, is not suppressed. But if they contract the virus, they are at higher risk of having a thrombosis, a clot. The virus causes thrombosis by its own. It doesn't need the vaccine or whatever. If you get the virus, your risk of getting a thrombosis is 2 to 3%.
Okay.
Okay, it's like 2,000 times more, 3,000 times more than the vaccine giving you the clots.
Okay, thank you. Our next question is from Donna. What is your opinion on holding your NSAIDs before or after the vaccine?
No particular effect. This stands for non-steroidal anti-inflammatory drugs. We're talking about naproxen, ibuprofen, Motrin, Advil, Aleve, whatever you have. Okay, Celebrex, all these medicines. No effect on the immune system, no effect on the response to vaccine, no nothing. Don't worry, don't stop it before or after. Everything will go well.
Okay, the next question. What is the guidance on stopping medications after vaccination and which medications?
To stop medicine after vaccination. What we have seen from other vaccinations was that methotrexate could be on hold for 2 weeks before the vaccination. Okay, for the flu shots and for other shots. If we could do that, we could get like a more robust response to the vaccination, so more antibodies and more protection, right? For COVID-19, there's no such guidance. And I would say for the moment, don't take any risks, don't take any chances, and don't stop your medicines unless you have talked to your doctor. If you have a stable disease for like 5 years or 10 years, probably nothing will happen if you hold your medicines for 2 weeks. If you don't have this thing, you can go to a flare, and the flare will be tough. Okay, so unless you talk to your doctor, don't stop anything. What concerns me is this, that if you're taking these medicines, there is a good chance that you will not build enough antibodies. Right, so what can we do for this? Second shot as soon as possible, I mean in 3 or 4 weeks as we did in the trials. Second shot and measurement of the antibodies to make sure that we have enough. Most likely. That would be like if you were asking me to write a letter to the Ministry of Health or something, I would write exactly this, that we have data that our patients are not responding as well to the first dose, right? And the system has been built to vaccinate everybody with at least 1 dose, right? So I would like our patients, our lupus community, to say that, look, we have patients here who are taking the same drugs that the transplant patients are taking. And they should be treated equally, and they should have the chance to get the vaccine on time.
Okay, right. Go ahead, Sarah.
Okay, great. Our next question is, would you recommend AstraZeneca vaccine?
AstraZeneca vaccine. I know probably all of you who are expecting this question, right? But anyway, I'll tell you what's happening and what is my opinion. If you were in the shoes of the Minister of Health, you would vaccinate 500,000 people with a vaccine. By vaccinating this, you prevent at least 25,000 deaths, right? Because the vaccines have the efficacy of 95% or 72% or 89% for the Novavax. This is for COVID-19 disease. When it comes to death or ICU admission, it's 100%. We're talking about 99.9, something like this now, right? So you will prevent 2,500 deaths after 500,000 vaccinations in Canada. I'm talking about Canada. From the other side, you had 500,000 vaccinations with one of this clot. As a decision maker, you will say, okay, let's have the vaccine, right? Because the balance is crushingly in favor of the vaccine. What can we do to prevent this? We should, in my opinion, we know what this is. We know why this is happening. It's an immune reaction to the vaccine, to a specific protein of the vaccine. It's very rare. We can't predict it, but we can prevent and we can protect patients with previous thrombotic complications. So if a patient, for example, we know that what is happening is called thrombotic thrombocytopenic purpura. Anyway, huge name, I don't want you to remember it, but we have seen this in lupus patients, right? Would I advise my patient with a history of this thing to go have this vaccine? No, no, I wouldn't, because I couldn't do this to myself. And since I couldn't do this to myself, I couldn't advise it to my patient. If I didn't have any history of clot, I could do it. I wouldn't be afraid. The cases, particularly now that we know what is happening and what to do, actually are not fatal. In the beginning, they didn't know what to do in Europe. And this complication had the mortality rate of close to 33, 34%. Now that the others that in Canada we didn't have, both of the cases are doing well and recovering at home, and most of the European cases are recovering at home as well because we know what to do, right? So I would say yes, unless you have a history of this thing.
Okay, thank you. So next question, are we at greater risk with or without the vaccine?
Greater risk of what? If you get the vaccine, your risk of getting the virus is 5% or 10% or anything like this after the first 2 weeks from the first dose, okay? Not tomorrow. Your body needs some time to build the antibodies for anybody. It's not only for lupus patients. Lupus patients actually will need more time. Like the study I showed you, 1/3 of them did not have antibodies after 3 weeks almost from the first shot. Okay, so the question is not if we have the shot or not. The question is to get 2 shots as they did this in the trials, like in 3 or 4 weeks for Pfizer and Moderna respectively. And not wait for 4 months. For 4 months, if, for example, now as we speak, we are 98 participants here, right? If we vaccinate ourselves like magically, 33 of us will not have any antibodies and will go out there for the next 4 months until the second shot without knowing it. And they will get the virus and then we'll say what happened. These people were vaccinated and why did they get infected? They got infected because they didn't have antibodies. Because we should have realized this earlier and protected them. Yeah.
Sorry, great, thank you. Next question is, will the lupus clinics be testing patients for antibodies?
This is what we asked our federal government money for. We submitted the grant last week. We have 17 centers across Canada. It's a Canada-wide effort from sea to sea. I'm a part of it. The McMaster Clinic is a part of it. I'm the representative from McMaster. We are trying to get our patients and measure the antibodies as soon as possible after the first dose, in order to have some Canadian data to show to the government. Right, but I don't have any reason to believe that Canadians will be different than Americans. I believe that we'll have the same findings.
Okay. I think you answered this earlier, but I will repeat it because it's here. Basically, you know, what your suggestion was as far as to get into the Ministry of Health. But the question is, will the time between vaccinations be less for lupus patients when we get more vaccine in Ontario? 4 months seems like a long time, which you already just addressed, but I don't know if there's anything else you would like to add to that.
The general plan is to call patients earlier than 16 weeks when we have more vaccines. But this is not certain, and nobody can promise that. Last week, we were supposed to receive 1.2 million doses of the Moderna. We got half the doses. Right. I'm volunteering here in Hamilton for 3 days a week, 3 shifts a week, and I'm working one because we don't have, the inventory is not great. Right. So we've had some trouble with the supplies, yes. But the plan is this: when we get more vaccines, now they say that we'll get 8 million doses from Pfizer. I hope we'll get it. I hope we'll get it. I will be the first to vaccinate people out on the streets, right? But I don't know. I can't promise this.
Thank you. Next question. Are you saying?
I can add something. I received my vaccine a month ago. Okay, the Pfizer vaccine, and I'm trying to get my second dose. The clinics, the vaccination clinics are wasting very few doses each day. Okay, why? Because these vaccines, when they come out of the freezer, you have 6 hours to administer this. If this, and you cannot get it back to the freezer, right? If it's out of the freezer, it's done. So we are trying to vaccinate people working there, working in this clinic, staff. Sometimes we call to the hospital for doctors to come in and get the second shot, in order not to waste this. Okay.
Sorry, my mic. Are you saying the patients who are on CellSep will not be able to build antibodies? Does this mean that I am not protected at all?
Patients who are on CellSep, 80% of them, more than 80% of them, were not able to build antibodies right after the first shot. So that's why I would suggest, okay, have your second shot at 3 weeks and not at 16 weeks, and then we'll measure the antibodies again. Right, and if it doesn't work again, we'll have to follow different approaches, like hold it for a couple of weeks, if possible. Go to a third dose. We'll see. But what we now know is that patients on CellSep, 80% of them will not build enough antibodies.
Okay, thank you. Is there a higher risk of blood clots for a young female versus an older female who receives the vaccine who also has lupus? And what about postpartum breastfeeding females?
Females are more likely than males to get this complication. Okay. To make it clear, we are talking only about the AstraZeneca vaccine. We haven't seen anything with the Pfizer or the Moderna vaccines. Okay, this is for sure. And after 300 million doses worldwide for Pfizer, we can be certain that it's not happening. Young women are more prone to this. like less than 55 for the Europeans. Now we say we stretched it in Canada down to 40. I read today, and they asked that we'll do this in people between 40 and 55. We know that it happens in women in more than 95% of the cases worldwide. In Canada, it's 1 and 1, but it's like the sample is very small. I would say that the younger woman has a higher risk than an older woman, yes. What was the other question, Sandra?
That was pretty breastfeeding, regarding breastfeeding.
Breastfeeding for both the mRNA vaccines are safe. We know that for sure. We have data on this. Okay, the mRNA vaccines are the Pfizer and Moderna vaccines. Okay, the others are different technology. Next question.
Yes, next question. I had COVID back in October, and I'm still enduring some symptoms. Have you had any input for what they're calling long COVID?
Yeah, I'm seeing this, Sarah. I don't know who asked this because I'm not following the chat. I like to see your face on the screen. But anyway, it's hugely important. It affects 10 to 15% of patients with COVID. And I think that we'll have trouble in the future. In Hamilton and elsewhere, we are building up long COVID clinics based on respirologists, the lung doctors, and rheumatologists like me. We have seen autoimmunity in most of these patients. And actually, the more severe the disease, the more severe the autoimmunity. If you end up in a hospital or an ICU, most likely you will develop autoimmune markers in the blood. Now, the question is how many of them will go on and develop an autoimmune disease like lupus in the future? I don't know. This is the grant we're talking about. I'm working with other scientists here. We have a group of 17 people, and we are working on this. What is happening is that the immune system goes wrong again. And I believe that this is autoimmunity, yes. It has to do with the endocrine axis and up in the brain, some trouble with insomnia, some trouble with more diffuse pain, some trouble with fatigue, some trouble with brain fog. We don't know what is this exactly. We are on our way to find out. There is a Facebook group, Long COVID Canada. They have more than 12,000 patients. Only if you're a patient, you can get in there. Right, and we are collaborating with them to get the patients we need for the study, for the research. It's already more than 12,000 people in Canada with long COVID. On Facebook, I can't even imagine like how many more.
So if anyone here is experiencing that, would they be able to get in contact with someone to assist with this research, or?
Yes. I'm here. They have Lupus Ontario have all my my contact info, everything. Right, Sandra?
Yes, sir. Okay.
So all of you would be more than welcome to send me an email. Okay, and we'll discuss.
Because I was going to ask that because we actually have a lot more questions, and I know you do have. You said you were available till 8:30. What I might be, I'm not sure if you are willing now that you've offered. I could compile these questions, and because I do know I do have the names. They're on the email, so I'd be able to compile them, send them to you, and then perhaps forward it back. But we do have about another 10 minutes, so we're going to try and get through as much as possible. The next question is Benlysta. You mentioned the chart appeared to say that Benlysta also means a lower antibody response. Did she read that correctly?
No, none of these patients were taking Benlysta. It's not rituximab. It's not the same. Rituximab and Benlysta are two different drugs, different. Okay, they are not the same. We didn't have any patients on Benlysta. What is happening with Benlysta, I would suggest, not based on data, but based on the mechanics of the biology of the drug, that you should get the vaccine in the middle. If you're taking the infusions, for example, it's monthly or in larger intervals, you will get this in the middle of the month. If you have your infusion on the 1st of the month and then the 28th, you will have the vaccination on the 14th. Okay, the minimum effect on the cells that produce antibodies is right in the middle. Okay, for the Benlysta only. For the rituximab is a different drug. It's active for 6 to 9 months. So if you had an infusion of rituximab, most likely you will not be able to make any antibodies for the next 6 to 9 months.
Okay, thank you.
Okay.
Next question. For lupus patients who are being monitored but not on any medications, do you know if they are developing antibodies after vaccination?
They do. They do very, very well, very, very effectively. I'm talking about patients on immunosuppressants, particularly the mycophenolate, Cellcept, or Myfortic. All these are the same drug from the chemical perspective. Okay, next question.
Thank you, Dr. Tselios, for the informative presentation. Given that lupus patient has an impaired immune function, how would I know that the vaccine will have the intended effect on my body?
Only by measuring the antibodies. By measuring the antibodies, we know that the antibody is the end product of a series of events in the immune system. So we give you the vaccine will be sensed by a specific cell that's called antigen presenting cell. This will go activate another cell, T cell. This will go activate the B cell. The B cell will produce the antibody. So all the immune system cells will be informed of this virus, of this vaccine. Everybody is informed. The entire army is alert, right? The antibodies are the soldiers, but the generals know in the back, even the cooks know when to cook for the soldiers. Okay, so if you have antibodies, you can be absolutely sure that everybody knows in the back. If you don't have antibodies, we cannot test this widely. Like we can test this in research laboratories and only in a very limited numbers. But the antibodies, we can do this in life labs. Right? It's widely available.
Great, thank you. Next question. I have been prescribed Omneris, which is a nasal spray containing a steroid. I have had one Pfizer vaccination. Would being on a steroid affect my ability to have the second vaccine dose?
Absolutely not. Go ahead and have it. We are only talking about high doses of oral prednisone or intravenous. Okay, sprays, inhalers, stuff like this, freely, no effect. Don't be afraid.
Okay, thank you. After the vaccine, are we able to request an antibody test from a healthcare provider? I was told they're not available in Ontario.
This is exactly my issue. I would love to have this for the lupus patients and other immunosuppressed patients, right? To confirm why and if they are protected. Right, I don't know now if Sandra will form antibodies or if Sarah will not form antibodies. There's no way that I'll know this. It will only be a guess. Right, maybe an educated guess, but still a guess. And since we have the test, and it's a simple blood test, it's not something so impressive or whatever.
While we're on that topic, can I just ask a quick question? Is it something that if we are willing to pay for, you know how some of these tests now you have to pay for them anyways when you go to the lab, would this be a test we have the option of paying for if we were willing to just to get this test done?
This test should be no more than $24 commercially. It's a single method. We know this method for 50 years. I was doing this for my PhD alone, for God's sake. It's all the, many of the tests you're doing this on a daily basis are based on this test. And it costs for example, to measure the thyroid hormones, right? It's $24 per test.
So if we request a requisition from our acting rheumatologist, letting them know we would like to do this test, they could send us the requisition, but we will just have to pay for it?
I think that most likely you'll have to pay. I don't know if the OHIP is justifying the expenses. I don't think so. Like outside of research purposes, right?
Okay.
But if you're going to do this, and if you're willing to pay for this, don't do this the next day. You will do this at least 2 weeks, 10 days after the second shot.
Okay, so you wouldn't worry to do it. What about, I think we mentioned earlier about there's cases where after the first shot, you don't develop these antibodies. So would you?
After the first shot, give it 3 weeks.
3 weeks, but if you're not able.
In the trial, they measured it, Sandra, from the day 18 to day 22.
Okay. So for the first dose, we give it, hopefully, if we're able to get the second dose within that 21 to 28 days. But if we're not able to get it, and we would like to, just to see if we have developed these antibodies, we could request this test. And if not, if we do get the second shot within the 21 to 28 days, then we would request this test after the second shot.
The transplant people had antibodies, 10% of them had antibodies after the first shot, 10%. After the second shot, it went up to 55%. Okay, and they were even discussing the third shot because they cannot stop the drugs. It's absolutely impossible. You don't have this strategy in transplant. You cannot stop the drugs.
Okay.
And that's why they had only the third shot in lupus. If somebody is stable, okay, I would give it a serious thought to hold the drugs for 2 weeks. Nothing bad will happen. Okay. And give some space to the vaccine to work. And lupus patients, it's not 10% as the transplant people. It's 66%. Okay, not that bad. But anyway, why don't protect the other patients as well?
Okay. Next question.
Okay, great.
Thank you.
I think you might have answered this, but are you concerned about any possible long-term effects or complications?
Complications for what? From what?
It doesn't say
From the vaccine.
vaccine.
Vaccines. From the vaccines. Complications. I would not expect anything. No. If you tell me, if we have data or anything, I will tell you that the data we have are 12 months old. The first person on Earth who received the Pfizer vaccine or the Moderna vaccine received that in April 2020. Right, so we have now 12 months data. Should we expect anything? I can't think of anything like so significant, so something that really to make an impact for this. Okay. We knew the technology of mRNA for the last 20-25 years. They didn't have the success up to now. Why? 1, they didn't have the money. 2, they didn't have the money. 3, they didn't have the money. Now that the Moderna got about $1 billion from the United States of America to develop this, they developed it. Right, and I hope that this will be the platform to see vaccines for various forms of cancer, for other diseases as well. But anyway, from the mRNA vaccines, no, I don't expect anything. No.
Well, it is about 8:30. I do want to respect your time. You did say you had until 8:30.
8:30 already? Oh no.
Yes, it is actually already 8:30. I know time has gone by so fast. So, like I said, for those of you, I know there's a number of questions. Again, if you would like to review some of the information that is in this presentation, it will be available. So Dr. Tselios, should I take these information and try and send you? I know it will probably be over time to get these answers back, but would you be willing to answer the additional questions I have if I forward them to you?
Absolutely, absolutely, absolutely.
Okay, so for like I said, there is a number of questions, and
I understand there's a lot of questions.
Yeah.
Linda, you can hear me, right? Okay.
Linda she's on somewhere.
Sandra, if we say to have another meeting for 1 hour, like say in 10 days, we'll do it or not?
If I can just
How feasible is this?
What I can do is we can certainly get that out. If you send a date and a time, if you would like to do a follow-up, and for those who are on the call who would like to come back and join us.
The questions are lots, I understand. I would be willing to do this if the participants are in agreement.
Okay, so if I'll just put it on galley view, and if I just get a wave of hands as I scroll through the different windows, and then what I can do, like I have a contact of if everyone that's on this call, actually maybe not everyone because we had a number of people register. So I'm not sure exactly who is on here, but I can send a general email to all those who had registered for the webinar, and then we would be able to do that. So, okay, so I'm just going to go back to the first page, and if I can just have wave your hands as I go through. Okay, I know some people are not on camera, so that's fine. Okay, so what we will do, we will get a date from Dr. Tselios when he's available. I will also, because we do have a number of meetings that we do have on different nights, so we will work something out that works for him as well as for us that would like to come back, and I'll send an email out to all of you, and then that will be just a question and answer session, of course, right, Dr. Tselios? Yes.
Yeah, absolutely, absolutely.
Okay, so let's plan for that. When I get the date, it will also we will have it posted, of course, on Facebook and Instagram. It will also be on. You could check under events section at lupusontario.org once we have the date, and there will be a link for you to register for that follow-up. Okay.
Okay. Okay.
All right.
Okay,
so I would just like to say a special thank you for everyone for coming tonight and for being such excellent participants. And I thank Dr. Tselios. He is my special doctor, so I'm a little bit biased. But I do appreciate you taking your time, and the lupus community do appreciate you taking your time to give back to Lupus Ontario. So thank you very much. Have a good evening, everyone, and I will do a follow-up via email, as well as please keep an eye at lupusontario.org/ and you just check the events section or go to the education section, and the new date and time will be posted for just the follow-up questions.